Welcome to the NGPG Quality Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment of the session. You may enter your questions into the Q&A section. A link to the event survey will be shared in the chat toward the end of the talk. And now it is my pleasure to introduce our speaker. Dr. Lawrence Justin Charles is one of our new additions to the Georgia Heart Institute Advanced Heart Failure section. He was born just outside of Washington, D.C. before moving to Ohio, where he grew up and did most of his medical training. He attended The Ohio State University for undergraduate work, where he majored in biology before taking a year off to do research and teach anatomy. He attended University of Cincinnati College of Medicine and went back to Ohio State for residency. He did his general cardiology fellowship and advanced heart failure fellowship at Vanderbilt University in Nashville, Tennessee. In addition to advanced heart failure, he is also passionate about the relatively recent field of cardio-oncology and sees patients in Gainesville and Dawsonville. When not working, he is spending time with his wife and one-year-old daughter. Welcome, Dr. Charles, and you can take it from here.
Thank you, Suzanne, for the kind words and kind introduction. Like she said, today, guys, I'm going to be talking to you guys about heart failure, but really heart failure readmissions. And I titled it, how to slow the revolving door, because we all know with heart failure patients, we see them in the hospital, we tee them up, we get them out of the hospital, and then soon after they go right back in. And so we certainly want to find ways to decrease this. But before we get started, I want to make sure we all know that I've got no disclosures. And I want to start with trying to figure out why this matters. I mean, who cares about heart failure readmissions? And the truth is, we should all care about heart failure readmissions because they affect the overarching medical system in America, but really nationally. This is a disease that is naturally progressive, that certainly gets worse if you're not taking medications properly, if you're not having a good diet. It's a huge burden on the American healthcare system, but these readmissions are often driven by things like congestion. So many comorbidities can lead to heart failure exacerbations. If you're not taking your medications or have medications not compliance, that can certainly worsen things and it lands you right back in the hospital. And then we have such a huge system here in really all of healthcare in America that there's certainly multiple gaps within the transition of care. And we should really be trying to fill those gaps, really encourage our patients to stay on their GDMT, which you'll hear me say a lot, that is goal-directed medical therapy. We need to be treating congestion, and we need to be able to use all the resources available to us and make sure we know those resources. Well, moving on, knowing that heart failure readmissions is a huge topic, we're not going to be able to cover absolutely everything today, but we do have somewhat of a framework for how we're going to discuss it during this presentation. I like to always start with, what is heart failure? What are we trying to treat? I think all of us physicians and providers seem to know kind of what heart failure is, some of the symptoms, but we need to know exactly what we're dealing with and how to identify it in order to truly treat it. Next up, we're going to be talking about the medications that have been proven time and time again to reduce heart failure hospitalizations, and by that logic, heart failure readmissions. We're also going to be talking about when to actually send patients to the hospital, because certainly there are times when the patients need to be readmitted. So we can't forget those moments, even though we're trying to reduce heart failure readmissions. And then obviously you're going to be referring those patients to cardiology or advanced heart failure cardiology and us. And then I want to make sure you guys know who we are here at Georgia Heart Institute in terms of the heart failure section and where our locations are. So first off, defining heart failure and kind of getting a sense of what it is. we've got some definitions here. We've got ejection fractions on the right side of the screen. I think it's very important to just know that heart failure is much more than just an ejection fraction. It is a clinical syndrome, and we've got that clinical syndrome here on the left, but I also have this next slide that is a bit busier, but I like it because it breaks things down really, really nicely. Again, heart failure is a clinical syndrome. That means it's a constellation of symptoms and signs in addition to structural changes in the heart or functional changes in the heart. It's often supported by objective data, such as imaging data, such as elevated BNPs or other elevated biomarkers. And there are also stages of heart failure. There's A, B, C, and D. And the important part to know is once you go forward, you cannot go back. This is a one-way street. We are not having patients that jump from A to C and then go back to B. It is once you go forward, you are there, you are stuck. And to really get at those stages, we'll have the next slide kind of break it down more. But in general, it is at risk when you're stage A. At stage B, you have maybe a change in your ejection fraction, some structural changes seen on your heart, maybe some valve disease, but you don't have symptoms. That's the key thing. You don't have symptoms. And when you are stage C, you have heart failure with symptoms. And then stage D is the patients that are on GDMT that are trying to do everything right and they have refractory symptoms. They have these symptoms at rest, they feel terrible at all times. And certainly in these patients, we're thinking about advanced therapies that includes heart transplant as well as LVAD, and then maybe even mechanical support, something we would do certainly in the hospital for a short term. And then there's also the classifications of heart failure. I think we all typically think of heart failure and think of heart failure with reduced ejection fraction. Just to be clear with the nomenclature, that is an ejection fraction that is less than 40%. And then there's heart failure with mildly reduced ejection fraction. That's going to be 41 to 49. And then heart failure with preserved ejection fraction, that is going to be an ejection fraction that is above 50%. Certainly, you guys will encounter, and we have encountered patients that have a really low EF, and then it starts to improve. And so we call that heart failure with improved ejection fraction. Going back to the stages again, the main through point here is that this is a one-way street. You won't be going forwards and backwards. It is forwards only. Stage A, essentially kind of everyone to some degree is going to be stage A because they don't have really heart failure. They're just at risk for it. But once you start to have some structural changes, maybe you've been seeing a cardiologist or you have known coronary disease, then you're going to be stage B because you have structural changes, but you don't necessarily have symptoms. Once you have those symptoms, including orthopnea, PND, or meaning paroxysmal nocturnal dyspnea, shortness of breath, chronic fatigue, lower extremity swelling, they're certainly going to be symptomatic. And those are the bulk of the patients that we come into contact with because they have symptoms, they have signs, and they're coming to get help or relief of their symptoms. And then, like we said before, stage D, those are going to be advanced heart failure patients. They have refractory symptoms. They're staying in the hospital a long time. They get out and they go right back. And sometimes they need, they need to be looked at for advanced therapies. And again, the main advanced therapies we're thinking of are heart transplant and then an LVAD. So moving on to our second point here is that there are known medications, very well-known medications that not only reduce mortality in several of the patients with heart failure, whether they're heart failure with reduced ejection fraction, mid-range or mildly reduced ejection fraction, or even preserved ejection fraction. They reduce mortality, so they help patients live longer. And then what we're talking about today, they help reduce hospitalizations. And again, by that logic, they help reduce readmissions, okay? The main four, we're often referring to them as GDMT. Again, that is goal-directed medical therapies for heart failure. It's going to be ACE, ARB, or ARNIs. We know those medications. That's the losartan, the lisinopril. We know beta blockers. We'll go over that in detail. You've got mineralocorticoid receptor antagonists. We also call those MRAs. There's three main ones that we'll go over in detail. And then SGLT2Is, so sodium glucose transporters 2 inhibitors. And so those two main ones are Jardiance and Farxiga. I often call them Coke and Pepsi with my patients because they're very similar, but they have different manufacturers. You can see here on the right that they all have representative trials that not only show, again, reduction in mortality, so we're helping patients live longer, but they also help reduce hospitalizations, which by itself is a marker for increased mortality or worsened prognosis with heart failure. So getting into some of the details about the first pillar of heart failure or GDMT, it is ACEs, ARBs, and ARNIs. So ACE inhibitors being lisinopril, enalapril, captopril, for example. They were really the first on the scene in terms of this category or class of medications. And there's been multiple studies, but one major one, SOLVED. The SOLVED study looked at ACE inhibitors, specifically enalapril versus placebo. And it looked at, well, do they actually reduce heart failure hospitalizations? And there was a 26% relative reduction in this study. And so you can go and look at the data yourself if you'd like, but certainly this has been shown to reduce heart failure hospitalizations and decrease mortality in heart failure patients. But ACEs also have side effects, which we will get to in the next slide. And so there is another, I call them cousins, a cousin of an ACE inhibitor called an ARB, angiotensin receptor blockers. And there's several of these, but the most well-known ones are losartan and valsartan, also candesartan. There's been several studies looking at hospitalizations decrease in heart failure patients, but the main one here that we alluded to was CHARM. Admittedly, this does use candesartan and ACE inhibitors in combination at the time, and so it's important to note that we would really never want to do that. Nowadays, we know very well that ACEs and ARBs should not be prescribed together. It should be one or the other. And so it's well known that if patients can't tolerate an ACE or if they're started on an ARB, that both are going to be decreasing hospitalizations. And then the most popular one nowadays and kind of the newest on the scene are ARNIs, which include Entresto, which has gone generic recently this year, or excuse me, last year. There are two main trials looking at this drug versus enalapril. So ARNIs versus ACE inhibitors to show which one was better for mortality as well as reducing heart failure hospitalizations. And so the Paradigm heart failure trial looked at Entresto specifically in your kind of standard stage C patients as opposed to decompensated patients that are usually in the hospital. That's what Pioneer HF or Pioneer heart failure trial looked at. And both of them showed that there were significant decreases in mortality, but also in heart failure hospitalizations. Now, going into some of the side effects with these medications, as you may not be prescribing all of these medications out there, but certainly you will encounter them and you want to know what to look out for. Well, all three medications are also fairly well known as high blood pressure medications, so antihypertensives. By that logic, they can certainly cause hypotension, and with hypotension comes dizziness. So you're certainly going to want to be managing the patient's blood pressure or paying attention to at least your patient's blood pressure, which you would normally do. They can also cause some hyperkalemia as well. Certainly not as bad as some of the other medications that we'll be discussing later on. They can have or cause a transient rise in creatinine. And so in the short term, they can worsen renal function. There's a a well-documented physiologic process as to why they worsen renal function for a short amount of time, but this does tend to get better. And in general, the benefit of this drug outweighs the risk of worsening renal function. And then on the right, we've got some class-specific side effects, specifically angioedema or a dry cough is often seen with ACE inhibitors, so lisinopril, captopril, and enalapril. Losartan is usually and historically used when patients have these side effects with an ACE inhibitor. And so they can be started on their own or they can be transitioned to from an ACE inhibitor. And then there's ARNIs, certainly Entresto you don't want to combine with an ARB or an ACE inhibitor. And when you are transitioning from lisinopril or any other ACE inhibitor to an ARNI, something like Entresto, you want to make sure there's a 36-hour washout, usually just to make sure patients don't overlap this. I just have them wait 2 days before taking the Entresto if they had been on lisinopril. So I end up doing 48 hours. Just some general practice monitoring tips. You're going to want to be checking, obviously, their blood pressure, so their vitals. You're going to want to be checking BMPs when you're making changes to these medications, just so you can keep track of their kidney function and their potassium. Next up, we've got beta blockers. I think we're all very well versed in beta blockers. They've been around for a very long time. In heart failure, there's 3 main ones that have shown the best efficacy and the best data in terms of decreasing hospitalizations as well as mortality for heart failure patients. It's going to be metoprolol, specifically metoprolol succinate, carvedilol, and bisoprolol. And each of those medications have had their respective trials that have been shown to decrease, again, mortality, but the most relevant thing here today, heart failure readmissions. Certainly, I want to kind of debunk this. I think it's sometimes commonly stated that metoprolol is a blood pressure medication. Metoprolol and bisoprolol, again, are beta blockers. Beta receptors are on the heart. When they are stimulated, the heart rate goes up. So if we're blocking them, we're going to be slowing the heart rate. Carvedilol, however, is an alpha receptor and a beta blocker. Excuse me, an alpha antagonist and a beta blocker. And so that is going to be better used for blood pressure. Certainly, carvedilol can lower your blood pressure, but metoprolol and bisoprolol really aren't affecting your blood pressure that much. And so those medications are really safe for patients that have relative hypotension. Now getting to some of the side effects from beta blockers. The first one, kind of logical. We know beta blockers slow the heart rate down. And so if you slow the heart rate down too much, you're going to get bradycardic. And when you're bradycardic for too long, and you're not able to increase your heart rate when you're up and doing activities, well, you get really, really tired and you have reduced exercise tolerance. And so that is a known side effect of this medication. Certainly, you're not trying to start a beta blocker on someone with a heart rate at rest that is around 55. Certainly not wanting to increase their dose of the beta blockers, as well as you would certainly precipitate bradycardia. And when your heart rate is too low and it starts to affect your blood pressure, well, that is a bit of an emergency. And so it can cause hypotension through that aspect if you're too bradycardic, or it can cause hypotension when it's postural, meaning when your patients are changing positions. If you're on a beta blocker, your heart rate can't correct itself for gravity fast enough. So it can't raise its heart rate fast enough. And so certainly that can cause the patient to feel a little bit dizzy at times. You want to be mindful of those things, but certainly, again, the benefits of these drugs outweigh the risk of them by and large. And so we certainly start patients on these medications fairly frequently. And you're typically starting slow, you're starting low, and you're going slow when you're increasing them. Next up is mineralocorticoid receptor antagonists. We often call them just MRAs. They are well known. They're pretty old drugs. There's three main ones. There's spironolactone, eplerenone, and the newest one is finerenone. All three have been shown to decrease heart failure hospitalizations. Now, specifically, spironolactone and eplerenone are well known and definitely decrease mortality when it comes to heart failure with reduced ejection fraction. When it comes to heart failure with preserved ejection fraction, they don't necessarily decrease mortality, but they do help decrease heart failure hospitalizations. And so they're going to be very important to use. Finerenone has been recently shown, 2024, to actually reduce mortality in heart failure with preserved ejection fraction. But it's not technically approved or really being used in patients with heart failure with reduced ejection fraction. But all three are fairly well tolerated. They have some side effects that we will certainly go over on the next slide, but they have all three been pretty squarely known to decrease heart failure hospitalizations. So MRAs as a class, the main side effects are hyperkalemia, and hyperkalemia. These are the main things you want to look out for when you are starting a patient on these medications or monitoring a patient on these medications. Or if you're just checking labs and you see that someone has a quite high potassium, albeit one that is above 5, you're going to want to see if they're on one of these medications. And you can certainly temporarily pause it and then check labs again to make sure their potassium has come down. But that is really the main side effect or the main thing to watch out for. Certainly in patients that have pretty poor kidney function at baseline, we want to be very leery of these patients as the kidneys help regulate your potassium. And if you're putting them on a medication that's going to raise their potassium, well, then the potassium can get very, very high. And so you want to be careful using this medication in CKD patients that are, stage 4 and worse. Certainly it can cause hypotension, but it's not a very strong antihypertensive. It's often used with other antihypertensives to control blood pressure. Hypotension with this medication is usually seen in patients who already have pretty poor PO intake. They're certainly just not eating or drinking the greatest. So some specific effects for each medication. Spironolactone is the most steroidal of them all, meaning you can have some steroid or sexual side effects with this medication. The most well-known one is gynecomastia in men and having some breast pain. If that happens, you can certainly switch the patient to eplerenone, and usually they're able to tolerate this medication much better. And then finerenone, the newest one, is non-steroidal. That's just kind of major difference from the other two in its selling point. But hyperkalemia can also happen, but usually is not as bad as the other two. So moving on to SGLT2s, SGLT2Is. Again, these are the Coke and Pepsi, the Farxiga and Jardiance are the two most well-known ones right now. There's been a multitude of data. These are probably my favorite heart failure medications to prescribe because you get so much benefit with them and you get so much bang for your buck. So they're good, obviously, for diabetes, and that's the way they've started. We've seen those goofy Jardiance and Farxiga commercials on TV. So it's good for diabetes, but it is also squarely good for heart failure, whether it's reduced ejection fraction, mid-range or mildly reduced, or a preserved ejection fraction. They've been shown, again, to reduce mortality as well as heart failure hospitalizations. And we did, but there have been multiple trials in kind of all of the classifications of heart failure, whether it's a reduced ejection fraction or preserved, and the data has been tremendous each time. So these we're really high on. We're really trying to get patients on. Unfortunately, they are typically a bit more expensive than the other medications as they're newer. The good news is Farxiga, one of the medications, is uh, going to be going generic this year. And to just make sure we know what Farxiga is dapagliflozin. So that'll be going generic this year. So hopefully that'll be much more affordable to patients. But both of them, you get a lot of bang for your buck, and they're very well tolerated, although we will go over those side effects now. Main side effects with these medications is genital or mycotic infections. So yeast infections and urinary tract infections, men and women, they're usually not severe. They're usually not causing sepsis. They're a bit of a nuisance and probably slightly more seen in women, likely due to anatomy. But usually if you have them once, we can treat it and then try to put you back on this medication. But if you're having 2 or 3, then certainly you don't want to stay on this medication, as at that point it's probably doing a bit more harm than good. Certainly these medications work, at least the way we know they work, is they block sugar or glucose reabsorption in the kidneys. And so they essentially make you urinate more sugar than you would typically. And so it can cause urinary frequency, some polyuria. In general, these medications should not be used or should be paused in patients that have really poor oral intake, as it can really cause them to be dehydrated. And honestly, rarely, but it can cause them to have euglycemic diabetic ketoacidosis. Certainly, these are the medications you want to stop before someone goes into a surgery, usually 3 days before. But you don't have to worry about tapering them off. You can just stop it, and then they can go back on when it is safe. So we went over the 4 main pillars of GDMT, but we all know diuretics, specifically loop diuretics, are used to target congestion in heart failure patients. The main examples of these is going to be Lasix, which is furosemide, torsemide, and bumetanide, also known as Bumex. There's not that much data to support how well these bring down heart failure readmissions or heart failure hospitalizations. But if you think about it, most of the time patients are being readmitted or being admitted in general with congestion. And these are our main medications that decongest patients. So you're going to want to make sure these patients are taking their diuretics at home, or at least being hyper diligent about weighing themselves at home to make sure they're not gaining weight before they have, lower extremity swelling or have worsened shortness of breath. And then to go along with loop diuretics, there are thiazide diuretics, again, typically chlorthalidone, hydrochlorothiazide, and metolazone, that are used in kind of add-ons to help people decongest even more. Now, we'll get into the side effects because thiazide add-ons are not as commonly used as loop diuretics. So loop diuretics, the main side effect you're going to be looking out for is hypokalemia, low potassium, because that medication is basically blocking them from reabsorbing their potassium and their sodium, and therefore causing them to urinate out more than they would usually. Certainly, any medication that makes you urinate more than usual can cause volume depletion or hypotension in really, extenuous circumstances. You can also have an AKI if you're dehydrated. This autotoxicity, I believe we're all taught this, but I'll tell you, at Vanderbilt, where I was prior to this, we used pretty crazy high doses of IV diuretics, and I can assure you that all the patients by discharge could hear just fine. So I don't know that I've ever actually seen this, but it is a well-known side effect of loop diuretics. Thiazide diuretics, I mentioned that they are not as commonly used with loop diuretics as one might think. And it's really just because they can really take a strong toll on your kidney function. They can certainly cause hyponatremia, hypokalemia, and just in general, certainly worsen the renal function, certainly quicker and much more than loop diuretics by themselves. So this next slide is just a good summary slide of what we talked about here. Again, ACE arbiter RNAs, beta blockers, MRAs, and SGLT2Is or inhibitors are going to be the four main pillars, four main medications we certainly want these patients to be on and to be aware that they are on, because they really do. They're the kind of the core medications to keep patients out of the hospital and help them live longer. Certainly, diuretics help with decongestion. And then we have this corner over here in red where we have select add-ons. You don't have to remember or really truly think of these too much. Just know that digoxin has been shown to decrease heart failure hospitalizations, as well as hydralazine and isosorbide in combination. And specifically, the hydralazine and isosorbide dinitrate is used more in heart failure with reduced ejection fraction. They're essentially an add-on. They're not going to be the core medications we would use, but they have been shown to help. So here, getting a little bit into some of the strategy behind how we can improve heart failure readmissions. Certainly, if we're seeing these patients in the hospital, we're going to always want to reconcile their medications. I mean, you just looked at the list of medications that can be used. The patients are going to be on a lot of medications. They're going to be overwhelmed. And so making sure we reconcile their medications so there's no duplicates, and trying to make sure they're not on simple things that we know is going to cause damage, such as NSAIDs. But we don't want these patients to be taking Advil every single day for minor aches and pains. You certainly want to be monitoring their weight. Not everyone is going to document their dry weight, but certainly you're going to want to be hyper vigilant about at least getting the patient's weight while you're there in clinic and having their weight done reliably in the hospital. And then certainly you want to make sure you schedule follow-ups within 7 days. Certainly if they've seen the heart failure team in the hospital, it's part of our standard protocol to make sure these patients always have follow-up with us within 7 days. And so we can try to keep up with them and make sure they're staying out of the hospital and making sure their medications are straight and they remain decongested. Though, the 14 to 30 days, we'll kind of skip over that. Obviously, we're always trying to make sure we manage their comorbidities, but certainly support systems are going to be key in making sure these patients stay out of the hospital for as long as they can. So making sure they've got scales at home, making sure they've got a blood pressure cuff at home, making sure that they actually have some understanding of what's going on with their body. And then certainly social needs. I mean, the social determinants of health that affect absolutely everything within our healthcare system. And so making sure they at least get access to care. Do they have insurance? Do we need to send them to the Good News Clinic or other free clinics around town? And then making sure, they can meet their basic needs. These are things that you at least want to get them to the right resources. I understand we're physicians, we may not be able to do all of these, but certainly we would like to make sure they can get some of their needs met and get them to the right resources again. So we spent the majority of our time trying to keep patients out of the hospital, and that certainly makes sense. But when should we go ahead and actually send these patients to the hospital? Well, certainly vital signs are going to be key. If you are noticing a patient is hypotensive and symptomatic, and again, hypotension for me commonly is going to be a systolic blood pressure below 90. If it's staying below 90, they're certainly hypotensive, and you worry about their blood flow getting to their major organs. And so that would be concerning if they're dystamic and barely able to speak in sentences without, working very hard to breathe. That would be concerning. If they are hypoxic and persistently hypoxic on room air, that is also concerning. If they are continuing to gain weight, upwards of 10, 15 pounds, that would be concerning. Maybe you don't always have to send them to the hospital, but you can certainly try to reach out to our clinics and try to get them in with one of us, because we can do IV diuresis and try to get them a quick boost of decongestion in our clinics. But in general, vital signs and lots of symptoms at rest are going to be your major red flags to get a patient back to the hospital. Another look at that, just trying to put it in an algorithm form. So again, vital signs are going to be key, making sure they're not hypoxic. Those red flags are the ones we just touched on, but I wanted to make sure we highlighted any new acute coronary syndrome concerns. So if they're saying, I've got really bad chest pain, and they're describing it as someone sitting on them or having chest pressure, chest discomfort, and they're at rest, and certainly it's worsening with exertion, that is pretty concerning, and you're going to want to get them to the hospital. But that's also pretty basic. And if they have symptoms and they certainly don't have red flags and they're fairly stable, of course, if for some reason they haven't seen us in 7 days from a hospital admission, certainly reach out to our clinics. You can secure chat us. We've got no problems responding to that and being alerted, because we want to keep these patients out of the hospital, but most importantly, we just want to get them the care they need. So that's just another way to look at an algorithmic way to try to keep these patients out of the hospital. Another slide, just again, looking at some of the key takeaways from the strategic way to try to keep patients out of the hospital. Again, the first thing, we don't expect you guys to be heart failure physicians or to be managing heart failure all out there by yourself. We just want you to encourage compliance on these medications. They only work if you're taking them, right? And so many patients, especially nowadays, we're trying to find alternative ways to get better, not use these medications, but certainly it has been documented and well documented that if we're not taking these medications, heart failure is a naturally progressive disease, and things will continue to get worse. They will continue to go back into the hospital with congestion if they're not taking these medications. And certainly if they're having multiple side effects and they're unable to tolerate those medications, well, then of course, we don't want them to be taking anything that's going to be harming them. We certainly want to treat their congestion. That means making sure we have a good, at least, documentation of their weights. If they can weigh themselves, we want them to weigh themselves at home, and we want to make sure we have them on some form of diuretic, whether it is as needed or daily, or maybe 3 times a day, some level of diuretic plan. And then certainly we want to make sure we know the red flags, we know when to get them in. And certainly, please have no hesitation in hitting us up, referring patients to us, or simply, saying, hey, I think this patient needs to be seen sooner than later. We are constantly trying to get patients in. If they need to be seen, we have problem visits we can schedule them with. We can schedule for them, or we can see them, or we can try to decongest them again in the clinic and try to keep them from going back to the hospital. Just another slide on kind of when to refer. In general, if you start noticing patients are having fast weight gain, they're gaining 10 pounds in 2 weeks, 5 pounds in 5 days, that would be concerning for worsening heart failure. If they have orthopnea, they just cannot seem to lay down at night, or they have to start sleeping in a recliner because they can't sleep in bed without trouble breathing, certainly refer those patients to us. If you've tried diuretics in your clinic and they don't seem to really be responding, or they've got this persistent leg swelling, certainly refer us. It doesn't mean that they absolutely have heart failure, but we have no problem trying to make sure we evaluate them fully for heart failure. And then certainly if patients are concerned about their meds, I literally just saw a patient today where his PCP had stopped some of his medications and he really wanted to know why. And so they scheduled him a problem visit with me, and we just took time to go over those medications. And thankfully now we've got a clinic pharmacist that also helped me go over those medications with the patients, so they're very clear as to why some of the medications were stopped and why we're putting them back on some of these medications and how we're going to monitor them going forward. And then this last slide here, it's really just letting you know who is in the heart failure clinic, who's a part of the heart failure section. First up is me. I am here in Gainesville, but I'm also in Dawsonville weekly on Mondays. My partner, Dr. Acosta, he is here in Gainesville, but he is also in the Jefferson Clinic. And so if you have patients out that way, you can certainly refer them to Dr. Acosta. Dr. Egelum has been here for quite some time. He's at Gainesville, of course. He's in Brazelton. He's also in Beaufort, I believe, on Fridays. There's Dr. Rajay, who's also been here quite some time. He's here in Gainesville. He's in Brazelton. He's also up in Blairsville. He, of note for him, he does interventional and heart failure. So if we're sending patients to get caths, albeit right heart caths or left heart caths, he will usually be our go-to guy for those catheterizations. Dr. Heiner, who joined the group right around the same time I did, he is in Brazelton, and he's also in Bethlehem. And we also have a wonderful group of APPs, or advanced practice providers, that include Robin, who's mainly in Brazelton, Rachel, who I believe is in Brazelton, but also in Gainesville as well. And then our newest additions, Diana and Brady, they are also here in Gainesville. And so we've got a multitude of providers. We've been growing. We want to take your referrals. We want to help you guys out. We certainly just want to manage heart failure and try to, again, keep these patients out of the hospital. That is it. That was fairly long. Hopefully it didn't take too much of your guys' time, but please don't hesitate to ask questions. I guess now we're in the question and answer portion.
Yes, thank you so much, Dr. Charles. We do have a question that came in from Matt Hanley.
Okay.
And he is asking, for stage A and B patients, do you think we are being aggressive enough in treatment to slow or prevent disease progression, or should we be more aggressive? If so, what should we do differently?
You know, that is a wonderful question, Matt. I think for stage A patients, I think, you know, as long as they're regularly seeing their PCP, they should have their typical risks managed. I do think we could be certainly more aggressive in stage B patients. I mean, now we've got structural disease of the heart and we don't have symptoms, and we don't have symptoms yet. So I do think it's important to get those patients over to heart failure and or cardiologist, general cardiology. I do think this is where general cardiologists within heart failure really play their role. And I think that would be, if you see a stage B patient, making sure at the very least you get them to a general cardiologist to, again, be closely monitoring these risk factors and monitoring them for symptoms. But obviously, we've got no issue if you feel like the patient is stage B, but you're not quite sure if they truly have symptoms or not. I think there's really no harm in going ahead and referring them to us. We'll be very diligent in our workup and in our history taking to make sure they don't actually already have symptoms. And really in stage B patients, we want those patients to be on, at the very least, an ACE, ARB or ARNI, and a beta blocker. Those are class 1 indications for that stage of heart failure. And so I do think there's always room to be more aggressive on stage B patients, but certainly at-risk patients, I think we're doing a decent job with that. But I think we can always be more aggressive with stage B.
Yeah. Can you hear me?
I can.
Oh, okay, great. Thanks. I was stuck on me. Now, first of all, great presentation. Really, really
Thank
good.
you.
And thoughtful. And the context of my question is sort of, it's a philosophical one.
Sure.
Right? And if I use the example of like coronary artery disease, there's a talk track out there or narrative of folks who say, the minute we know someone is at risk for coronary artery disease, we should kind of go all in on disease prevention. So it's sort of the subtle argument of saying, well, I'm seeing my primary care doctor and my cholesterol's a little bit high, but I'm a healthy person. I don't smoke. There's no family of heart disease. Do a little diet, and we give them the prescription of let's do some diet and exercise kind of stuff, and we'll recheck it. And that's sort of one philosophical approach, right? But there's another sort of conversation that's out there, sort of saying scientifically, listen, we know enough about coronary artery disease progression that like this is not a let's wait and see. It's like we know the things that cause plaque progression and we know it occurs over time. Let's be incredibly aggressive when we know you have risk factors but no disease or absolutely minimal, completely asymptomatic disease. So we're not having a conversation in 10 years because it's knowable how this is going to go, and be really, really aggressive about things like lipid control and stuff and blood pressure control. And so it's sort of those two opposite ends of the spectrum, the paradigm. I'm just thinking as it relates to heart failure, the A and B, is there a I mean, what you presented feels fairly comprehensive, but I don't know, you may say like, if I had my perfect world, this is all I do. Every stage, be patient, I would actually do, is there a different philosophy out there around, we should actually be, if we're really, really aggressive with these patients, they'll never become C and D. So that's, I just wanted to give you a little context for the question, but I appreciate your answer.
Oh, of course. I would say that I think we can have these philosophical discussions, and I think they're good, and we need them. But there's also just trying to preserve the patient and doctor relationship. And so because we have to preserve that, I think the answer is a bit nuanced. I think if we're too aggressive at all times, I think sometimes we're going to run some of our patients away. We may not have complete buy-in on our patients, specifically when it comes to heart failure, because many of the medications, many of the treatments are actual medications, right? Yeah. And so many of the patients I see are already telling me, I don't want to take any of these medications. And here I am trying to essentially sell them on 4, maybe 5 new medications. And so I think certainly we want to be as aggressive as we can, and we have the science, we've got the background for that, but there's also the real world. And there's a growing sentiment in America and really nationally that, hey, we don't want to take all these medications. We don't want to put all these things in our body, albeit there are other things that they're putting in their body. But we as the doctor have to find some middle ground. And I think if we err on the side of being aggressive right from the beginning, we err on alienating patients and them saying, you're just trying to pump me with medications, as opposed to, maybe tipping them off. Maybe if we notice they have some risk, taking the time, having that discussion and having that full discussion kind of then, and then every time you see them, kind of reminding them that, hey, you have these risks. There may be some medications in the future. We're trying to be somewhat conservative now, but at some point, and at some point near the future, near the close future here, we're going to need to add on some medications. And so the truth is that it's often so nuanced. They often, heart failure doctors at large in the societies are telling us, hey, put these patients on these medications and go up fast, go up on the doses fast. But in the real world, patients are like, I couldn't tolerate this, I couldn't tolerate that.
Yep.
They don't want to go up fast. And so I think we have our thoughts and our philosophies, but we also have to balance that with the patient's their outlook on healthcare as a whole and their outlook on just taking a bunch of medications. And so we have to find that middle ground.
Yeah, I appreciate, that's a thoughtful answer. Thank you.
Thank you
Wonderful.
so much, Dr. Charles. It was a pleasure.
Thank you. Thank you so much for having me. I really appreciate it. And look forward to maybe doing other presentations in the future. You guys have a good one.
Absolutely. Thank you, everybody.